if I can have our expert panel slowly drift in here. We've got many, many, many questions that have come in on a lot of very interesting topics. Excellent. So let me quick introductions, and apologies if I mispronounce any names. We've got Dr. Chen from the National Taiwan University Hospital. We've got Dr. D'Amato from the University of Miami, Dr. D'Angelo from Memorial Sloan Kettering Cancer Center, and Dr. Gupta from the Princess Margaret Cancer Center. And so if it's okay, we'll just dive in. And the way we're going to do this is I'm just going to ask one of you a question, but please, any of the others of you who have an opinion on the matter or any follow-ons, jump in afterwards and let's fill out the information as much as possible. So I'm going to start with Dr. Chen. And this is sort of on the topic of long-term stability and people's, what we often terms here as scanxiety, and there's a couple of questions around this, but one question is, what do we know about people who have been stable for a very long time and the risks of loss of that stability? Do we understand anything about the mechanism? Do we understand anything about the timelines? If you've gone a long time stable, does it give you better probability of staying stable? What do we know on those fronts?
Yeah, so based on what we know, like you said, I think once you have gone through like really being a stabilization path, I think it's more likely that you're going to stay the same. Definitely, we're still searching for like what are possible biomarkers. So I think that could kind of be a sign rather than just seeing on the scans. Are there any like blood biomarkers that could be associated like early detection? I think this is not just in the EHE, but in other cancer types as well. They want to know earlier, are there any signs that before we can really detect it? So I think there are a lot of things now ongoing. One is like the marker, like maybe GF15. There's something that we think maybe more of there. But I think at least for the anxiety part, I think once you're undestabilized, like for 1 or 2 years, my experience is that you're more likely to get it further. So we now have like patients over 2 years being stabilized. I would be more comfortable telling them that we can actually be more comfortable with this like staying for long. But definitely we do need more telling us like before the scans, or are there any better biomarkers that before any symptoms or tumor growth that we can say that we have to be more careful about this.
Excellent, thank you. And Dr. Gupta, sort of a follow-on question to that. When someone is stable for a long time and might move to more progressive disease, do we have any understanding of what causes that? And is there anything patients can do to help reduce that risk that we know of today?
So I agree with what Dr. Chen just said. In my own experience, I have not had that scenario happen. The patients who have achieved this, I think we've discussed this before, where I consider patients in 2 categories almost. The patients who kind of progress almost from day one, and then the other group of patients who really do have disease stability from day one. And we kind of see that even when we think about the Kaplan-Meier curve, so those curves that where we describe the proportion of events, we see a flattening of that curve, which means that there is definitely that proportion of patients who always will have disease stability and will just be living for the rest of their lives with spots that we will see on a CT scan. That's it, but will always stay invisible to that individual. So that person will never have any cancer or EHE related symptoms that they would find if they looked in the mirror or have any problems that they could report.
Question for Dr. D'Amato. So we often hear from EHE patients, one of the greatest sort of things they're dealing with day to day is pain. And question is, what are our options for treating pain in EHE patients?
Yeah, so pain is a very subjective thing, and you can have patients I'll see that have very big tumors, not necessarily EHE, but just in general sarcomas, and they won't have any pain. And then I'll have a patient with a very small pain tumor, and they have a lot of pain. So there's a lot of, there's a lot of things that go into what would cause the pain. It's a lot of it is the location of where it is. Is it along a nerve? And then also I feel that sometimes the scans don't always show us exactly where the pain is coming from. So, I've had patients where they're having a lot of pain, and I'm trying to get the scans and trying to figure out where the pain is coming from. But if you can find out where the pain is coming from, that's the best route, because then you can potentially target that one area. But sometimes, unfortunately, the scans don't show as much cancer as like, say, if we were to open you up and do a surgery, for example. But we don't want to be opening up patients and doing surgeries just to find the source of the pain. So I think it's important for patients to really speak up when they have pain. If their primary oncologist has attempted pain management and it's been unsuccessful, then most centers have palliative care doctors who are pain experts. So it's important. And there are medications that can treat it based on the location. Sometimes tumors can be painful, and radiation can be helpful if we can identify that that's the specific tumor that's causing the pain. We can radiate it. Otherwise, there are other potential procedures, but it's important to know where it's coming from.
Question for Dr. D'Angelo, and for any of these questions as well, if you have thoughts on any of the previous questions, feel free to sort of share your thoughts there before answering the new question I'm asking. With Dr. D'Angelo, some of the other symptoms people have that can be frustrating are fatigue and brain fog. I guess two questions along those lines. Are you seeing that with patients, and what are your thoughts on ways of dealing with those? Oh, it looks like your audio is not working right now.
I can't hear you. Maybe it's a microphone set up.
Well, keep working on your audio. We'll just shift that question to the other three while you're working on your audio. Any thoughts from the other three on brain fog or fatigue, and if you're seeing that prevalence, and how do you deal with it?
So, if you guys are okay, I can take over that. Italians will talk for each other. Our names are very similar. Anyways, I think so there's a whole cause of fatigue, and I call it the fatigue workup. There's many different causes of fatigue. Number one, sleep. So, a lot of times patients are not getting enough sleep because they're anxious and maybe they're uncomfortable with pain. Pain can cause fatigue. Also, anxiety can cause fatigue. Depression can cause fatigue. And then not eating properly, certain foods can cause fatigue, or if you're not getting enough calorie intake, calories are units of energy. And so those are all things that we can kind of assess what the patient may be doing that we can help. Then there's, of course, medical causes of fatigue, and I have a fatigue workup, and I check, iron levels, vitamin B12, folate, vitamin D. We check urine, and sometimes there's hidden urinary tract infections and such, and we can replace those. So I do, you want to talk to your doctor about what's causing the fatigue and if there's some things that can correct it. And then otherwise, if you do have it, there's ways to cope with it too, as far as prioritizing your activities. And then, of course, treatments can cause the fatigue, but we want to eliminate those other things and try to correct as much as we can before we blame it on the treatment. Then, of course, the cancer itself can cause fatigue. Again, treatment with the cancer can help.
Excellent. And Dr. D'Angelo, let's check your audio here real quick.
Can you hear me?
Perfect.
Now we can.
Oh, perfect. Thanks. Sorry.
Question, if you have any thoughts on sort of the brain fog side of that question.
Yeah, the brain fog also can be challenging. Sometimes we do see that in the context of certain chemotherapy drugs in the midst of treatment. I think that, like fatigue, there's not one specific antidote to make it better. I think that just some general approaches that can be considered is one, really trying to understand if this particular symptom started in the context of the therapy. And that requires a lot of sort of thought and almost analysis. When did it start and what does it feel like? And so there's one piece of that. There are some avenues to do neurocognitive testing and working with our neurology colleagues to really try and discern if there's a specific trigger for the particular symptom. Many times, though, which is a little discouraging, is that we don't find an actual solution or underlying etiology for this particular symptom. And so I think best supporting the patient a number of different ways becomes important depending on that particular patient. Different activities to promote and stimulate brain activity. For some patients, it may be exercise. For other patients, it may be yoga. So engaging the broader sort of multidisciplinary team that's involved in the patient care, I think can be helpful to help address some of these symptoms.
Question for Dr. Chen, and I'll open this up to everyone after Dr. Chen answers it as well, because it's a commonly recurring question. And maybe it doesn't have a very precise answer, but we'll see what we can get to. And it gets back to that issue of stability. Is there a definition for stability? Because I know some that would keep you in sort of a watch and wait versus a treatment paradigm. And, can you have some growth and still be considered stable? Does size of the tumors matter? What kind of goes into our assessment of what's stable and what's not, and when do we treat and when do we not treat?
Okay, yeah. So I think that's a very important point. I think a lot of times, I mean, for localized EHE, I think like local treatment, surgery, probably the main stage to go. But I think a lot of times it's when we see patients, even they have the like primary tumor resected, we do see some spots like lung metastases or liver metastases, where I think that's where it's the tricky part. But I think most of the times we will give it some time to monitor how it goes. So what's the progress, what's the process of disease? And then I think that goes to what your question is, how to really define the stability. And I think first, like Dr. Gupta and we have mentioned, is that there are patients who are really understabilized. Although we see them as a stage 4 liver lung metastatic patient, like in a year, 2 years, there really no change. I have patients who on this follow-up for 5 years, there really no change in any of their lung metastases. So they kind of look very well. Sometimes you do see some small dots, and that's the time where I would take like, what's the time between, like what's the speed of its change? There's really no, I think there's really no definite answer. I would like to hear from the other experts as well. There really no definitely kind of change, and that sometimes it also correlates to where the tumor is, because we have to think physically. Different organs you may have different criteria as to when is the best time to treat. We do know that if you do have like effusions coming out, and I think Dr. D'Amato did mention about like the pain. Sometimes the pain comes before where we can observe the tumors coming out. In my experience, sometimes is before the effusion comes out, there may be pain before that. So I think that's something we also have to take into consideration as well. So even there's nothing on the CT scan, we do like put into quite a consideration of a new pain that coming out of your symptoms. So I think definitely there's no one size fit all answer to there, but I think these are something that if you have a scan, the way the speed it changes in different organs, I think different physicians may have different thoughts about that. The other is, are there new symptoms such as pain coming? Even without CT scan, we do have to be careful, more closely monitor, are there any likely changes in the future?
Excellent, thank you so much. And Dr. Gupta, I'm going to ask a kind of a related question, and this is sort of new patient anxiety. So if a new patient comes in and they're not showing aggressive disease, new patients always are going to have a gut feeling like, let's do something. But What are your thoughts on seeing new patients where the disease is not aggressive and sort of the timeline of figuring things out?
I think that the theme of the questions and the themes of our answers are actually kind of, to me, always honed down to one thing, which is the idea of living with chronic disease that is also labeled as stage 4 cancer. People live with chronic disease all the time, like diabetes, hypertension, but all of a sudden, when we call that chronic disease stage 4 cancer, it's a whole other level. So we're asking patients to go home and live their lives and go to sleep and wake up the next morning as if nothing's happening to them. It's really easy for the physicians on this side of the panel to say that to an individual. It's very difficult for the person on the other side of the room to accept that information. So at the beginning, when we first meet so first of all, I will back up and say that when we looked at actually all of the patients in Canada, more than half of patients actually presented with EHE as an incidental finding because they went into hospital with a completely unrelated problem. And which implies that for many, many patients, more than half, the EHE has probably been there for years, and they just happened to have a CT scan that picked it up. So if a patient presents for the first time and seeing me in consultation for the first time, the most important thing is the same thing that happens even later, is what is the pace of the disease. So at the beginning, for all of my patients, my practice is to do a scan, let's say every 4 to 6 months at the beginning. So maybe for the first 2 years. But as soon as we understand that the rate of disease is stable, that's it. My own personal practice is to only scan individuals once a year. And sometimes to me, that's also a lot because we know that nothing is going to change in those scans. And so at the beginning, just like with any new individual entering a cancer system and cancer center, of course, it takes time to appreciate that. And also it takes time to appreciate that because every single individual who's had a diagnosis of EHE, at least for us, has had a prolonged diagnostic journey because nobody knows up front with that initial pathology done at some community hospital, like what the heck is EHE to begin with. And so the amount of distress that has been created by that diagnostic and prognostic uncertainty, I think also exacerbates the kind of the implications of the consultation moving forward.
Yeah, makes that challenging to deal with. Dr. D'Angelo, a question for you, and we always get these questions every year, and we always keep learning more, so I'd love to hear your thoughts. And we have a slightly more specific version of this, but the general question is, what should patients think about in terms of things they do with their day-to-day health outside of their interactions with the medical system that might be helpful or hurtful for the disease? And we have a specific question this year that hasn't come up before, so I'm going to ask the more specific version. Any thoughts on the benefits or harms of like sauna and cold plunge therapy, heat or cold? But I open that up to anything, diet or anything else people can do in their daily lives that might be helpful or harmful.
That's a great question. I think that we're learning more and more about how to integrate therapies into our therapies as medical oncologists, right? So I often tell patients, our approach is sometimes very specific. We study a drug, we prove it works or doesn't work, and then we recommend that drug. But obviously, there's a whole universe around that journey, and depending on the patient, there's different needs and priorities that need to be considered. So you can think about a few different things. So one aspect is supplements and integration of supplements into the treatment plan. Personally, I'm not an expert in supplements. I caution the use of supplements without having an expert involved. So at MSK, we do have an integrative medicine department, and if supplements are something that patients want to include in their treatment, I often will engage that team. I will say that though, things that seem benign are not always benign. So a very simple example of that is probiotics. Many people take probiotics. It helps a number of different things. In the context of immunotherapy, actually, a clinical trial was done in melanoma patients, half of whom took probiotics and half who actually used increased the fiber in their diet. And what they found is that those patients that took probiotics were less likely to benefit from immunotherapy. So something as simple as a probiotic in the context, a very specific context, obviously, it's melanoma, it's immunotherapy, it actually can decrease likelihood of benefit. So to that end, I'm always hesitant to just say, oh, take whatever supplement, it's probably fine. I think that there needs to be a little bit more thought put into that. So the second aspect is sort of how do you integrate information that is so readily available that may or may not be accurate. And I think that the power and the pain of social media, right? You have access to a lot of different information, and some of it is helpful and some of it is not. And how do you vet that out? And I think empowering patients to come to you as their physician is important, because I think in the end it's on us to sort through that information and make sure it's good information or perhaps not applicable to the particular patient at hand. So that's the second important part. Leveraging that relationship you have with your patient. Hopefully you've built enough trust that you're able to help guide patients. There's a lot of information about diet. Diet. We don't know the best diet for patients with cancer, and I am a little biased, and Gina alluded to this, but maybe the vowel at the end of my name suggests why I often recommend a Mediterranean diet. Lots of fruits, vegetables, and grains. Eliminate a lot of sugary foods, not a lot of red meat, but basically follow the food pyramid, right? It's been around for hundreds of years, so why reinvent that wheel? Exercise. Some of us like to exercise, some patients don't like to exercise, but more and more there's this whole field of exercise oncology that's emerging, and integrating exercise, I think, is actually a great thing if feasible and safe and practical. But in the end, I always tell my patients that being moderate in our approach and our behaviors and how we generally live life is probably a good mantra to follow in every aspect of life. Because I think that, not the same approach is going to work for every patient. We really need to personalize how we approach things, but we also don't want to be too extreme, whether it's with supplements or with exercise or with, diet. Seeking as much evidence-based advice, though, I think is very important, and making sure that that advice is correct and based on the best data we have with the implementation of many experts' advice, I think winds up being a general good approach.
Dr. Gupta, you had a follow-on question or thought on that?
I just wanted to clarify, Sandra, one thing about sugar, because a lot of our patients do ask about the impact of eating sugar. And just to clarify that, you're recommending in general, like, moderate, healthy diet, but not that sugar intake directly impacts sarcoma or EHE.
Yeah, 100%. Yeah, just generally speaking, being healthy and not having 5 Cokes a day is probably a good thing for most of us in society.
Right.
That being said, if you feel like having a Coke and a burger and fries once a week because you've worked hard and you feel like you want to indulge a bit, I think that's okay as well. Again, it goes through that philosophy of just being moderate in our approach and decision making.
Cool. Thanks.
Question for Dr. D'Amato. We've heard a lot today about some of the surgical procedures, and I think they have a lot more history with them. But now with treatment of EHE, we're seeing sort of an emergence of some new potential drugs coming online. We've gotten some peer-reviewed publications on drugs like sirolimus, and other things are being sort of experimented with and tested with, and there's things in clinical trials. When you're talking to EHE patients, they may be coming to you with some questions about these, early stage emerging potential future therapies that might be drugs rather than surgeries, and kind of get your thoughts about, is there anything you're aware of that's becoming more a standard of care or might be considered, and just how you deal with sort of like this quickly emerging science of, potential drugs coming and how to talk to patients about that and how to think about when it's ready to treat those seriously versus it's too early. What are your thoughts on that?
Yeah, sorry. So, my approach is similar to, I think, the panels here, is that, with certain cancers, you have to be more of a proactive approach. Like, the cancer is going to be bad, so you have to just really be aggressive with the treatment. But with EHE, we can be more of a reactive approach, right? So we want to analyze how the cancer is behaving, and then based on how the cancer is behaving, come up with a treatment plan based on that. So if we have a patient that's been stable and they're not having any symptoms, we certainly don't want to give them symptoms from side effects from treatment if their current disease is not quality of life or life-threatening, then we shouldn't be quality of life or life-threatening with our treatments. And so there are various treatments that are available based on how the cancer is behaving. So we have sirolimus, as you alluded to, or any of the potential mTOR inhibitors. We found that pretty much, they're similar. It's just a matter of what your insurance will cover and where you can get it cheaper, if you can get it free from the company, or if you can get it on Mark Cuban website, that Mark Cuban's pharmacy. You can get sirolimus for relatively inexpensive. Everolimus, you can get it from the drug company sometimes. So we have mTOR inhibitors that have been shown to be effective, and then we also have what we call VEGF inhibitors or tyrosine kinase inhibitors, which are more targeted to the certain receptor, vascular endothelial growth factor receptor. So that's like pazopanib and some of the others. And then we have also trametinib, or a MEK inhibitor. There's also a newer MEK inhibitor that's approved for plexiform neurofibroma. And so those are potential options. They are on the NCCN guidelines. I'm not sure about the access in other countries, and US. We can typically get them. Sometimes it's a hurdle, but we have resources in place. And then, of course, we always encourage clinical trial enrollment if there's a possibility, just because patients that are enrolled in clinical trials, we do have shown to have better outcomes. So if there's a clinical trial, that's great. For some very, very aggressive EHE, there is always chemotherapy that we can resort to. We try not to in patients that don't need it, but sometimes they do go awry, and we have to resort to chemotherapy. And when EHE does behave aggressively and we have to resort to chemotherapy, it can be effective.
And then one area we've been getting a lot of questions on is immunotherapy, which, historically for sarcomas has not necessarily been a successful approach, but because it's become sort of a hot topic, there have been a number of questions about, clinicians' thoughts on that as a potential option. Dr. Gupta, do you have any thoughts on immunotherapy as a potential future approach?
Oh, sorry, I do, but that wasn't what I was going to say. I was just going to.
Please add to whatever point we had last, and then, if you wouldn't mind addressing the immunotherapy.
Well, I actually love these panels because I actually learned so much from my colleagues as well. And I just wanted to, just emphasize, just to go back to the point of the indication for actually starting therapy. And so I want to make sure that it's, well, I guess number one, I'm curious as to the consensus of the panel, but also to send this message to the patient community. So number one, if a patient has stable disease and no cancer-related symptoms, I don't think any of us would suggest starting therapy, right, Gina?
Correct. Yes, exactly. It depends if it's life-threatening, how life-threatening, how quality of life-threatening it is, then we react based on where it's located, how threatening it is, and what we need to do about it. Yes, correct.
So we would not, for example, I would not start someone on therapy if they have a stable 1 centimeter lesion that's been there for a long time. Like, we are Agreed.
Anything's, yes, anything, and unless it's very painful, you know,
Right.
that one's stable and they're having a lot of pain, you may want to try to chase something down, but if they're asymptomatic, yeah.
Sandra and Tom, do you have any other comments about this? I think it's an important
I think
topic.
it's, yeah, so I think it's very important to really have a good communication, because our patients also hear from other patients with other cancers, or even their relatives, right? Or their friends. They're telling, how can you not treat, you have a tumor in you, you have a 2 centimeter tumor, it's, you know it's there, how can you not treat it? But I think this is where we can help, is we do know the disease. So if it is really confirmed EHE, we do know that you really do not have to worry too much about these 1 or 2 centimeters without causing any symptoms. That you may have a stabilized disease that for quite a while. So I think it's very important that it's good the experts already had a consensus, and I think the next step is really through the communication to really bring this concept to our patients so they can feel more comfortable that we do understand this disease.
Yeah, and we're just about out of time for the panel here. So let me close with a question to each of you, and I'll ask you to each kind of go around it and give comments on this one at a time. So we had the first part of this conference was yesterday. That was more of science-based, research-based. And I think what we saw coming out of that session was a lot of optimism for improvements in the future on how to treat this disease. And I'm just wondering, like, for those of you who've been seeing EHE patients over the years, kind of what are your thoughts on clinical care, how it used to be versus how it's going, how you see it in the future, and kind of what your views are for, 5 years from now when a new patient comes in the door? What is your level of optimism that they're going to see a more productive approach to the disease than, say, 10 years ago? And just kind of get your thoughts on what you're seeing with the trajectory of the treatment of EHE and our understanding of it. So start with Dr. Chen.
Okay, yeah, so I would say to actually have a more better, I think back to our first question, to have really a better, more accurate, or you can even say personalized assessment of the disease. I think the working with the EHE Foundation and from the Milan group, Dr. Silvia's technology, that we are now trying to come up with different assessment than just using the RECIST, where we use the scan to see how the tumor is growing. It kind of the new assessment now kind of incorporates whether how to really measure the effusion volumetrically, and to incorporate the pain, and otherwise, like we mentioned, the fatigue sometimes, and even the biomarkers, so we can take blood tests to see how this is going. So I think this is another part. We do know EHE behave very, very widely, but if we can have more accurate assessment, we can have more confidence in bring the prognosis to our patients, and then I think we're in that way we can even make it more easier to find a better treatment for each different groups and each different status. Yeah.
Dr. Gupta, your thoughts on the direction we're going and how we might be able to treat patients in the future?
I think having more ongoing conferences like this is really wonderful to be able to keep the EHE community connected. And I think that I personally would encourage the patient community to continue on both paths. Yes, of course, we're going to continue to try and identify new novel agents that will help with patients with progressing symptomatic disease. But the majority, 80% of patients with EHE do not need medical therapy. And so when I think about the quality of life of patients who do not have cancer-related symptoms, to me, if I was to think about a trial, that's what I would be focusing on, is improving quality of life with patients who are living with chronic EHE.
Yeah, that's an important point, and that's, I think, something we'll take to heart on the foundation here and think about supporting patients in every stage of disease as fully as possible. Dr. D'Amato, any thoughts about the future and what you're seeing?
I mean, I think the future is bright. I think as we learn more and more about the disease, we can, pretty much echo what everybody else is saying. We're really better understanding the mutations, understanding who needs treatment, who doesn't need treatment, and more targeted therapies. And so I think just the more research and we really want to thank EHE Foundation for all their support and supporting the research and having organized research and state-of-the-art research. That's what's going to help advance the field and give all the hope to the patients out there. So thank you, EHE Foundation, and thank you to all the researchers that are working tirelessly to help this disease in our patients.
Dr. D'Angelo, last words, any thoughts about the future?
So just to echo what's been said already, I think sometimes less is more. And when less is more, it's actually harder. And I think we all alluded to this a little bit throughout the last half hour or so. Not doing treatment is very hard and can be emotionally, physically very draining. But education and empowering, again, patients to work together to not do anything when appropriate is an important part of a journey of a patient with EHE. The second thing is that research is so very important, and I'm hopeful and optimistic about the future. There's a lot of new drugs that are being investigated, and studying the disease in the context of clinical trials, I think, is very important, and that's how advances are made. And so when appropriate, I encourage my patients to participate in a clinical trial because that actually pushes the field, and there are new and exciting options emerging across the broader field of sarcoma. So I think that the future is indeed bright, but luckily and importantly, we don't always have to do and intervene, and knowing when not to, I think, becomes very important.
Excellent. Well, I can't thank you enough for participating in the panel this year. And I'm going to turn it over to Denise Robinson for closing remarks on the conference.
Hi, you all can stay right there. It'll be fine. I'm not gonna stay on very long. I just want to say a huge thank you to all of you. The audience who's watching may not be aware, but we've covered a lot of time zones here. Tom is very late in his evening, and we're covering regions of the United States and North America, and we really, really appreciate the expertise that you've brought today. I think that, when we started the day, and David, you'll probably agree with me, I mean, the big takeaway today has been talk with your doctor and seek expert care with a team of people who really understand this disease, even if you can only do that here and there in consultation, if you can't quite transfer your care to an expert center. But I think that one of the reasons that the future is so bright is that the pool of people who are really knowledgeable in EHE has grown quite a bit. So we're not, we as a foundation, as advocates, are not limited to 3 or 4 or 5 institutions that we're sending people to. You all are growing the field. You're growing residents who are working with you and teams that are working with you as these patients go to your centers. So thank you very much. And I say the same thanks to the people who were here today before you and presented. So I do want to close and say thank you to the panelists, all of the panelists, and the patients and advocates who entered questions all that throughout these last 2 days, and our sponsors, Vivace Therapeutics. They gave a presentation yesterday, Dr. Gounder. It'll be recorded. So for those of you who missed yesterday, in a couple of weeks, we'll have recordings, or at some point in the near future, we'll have recordings out. You should listen to those presentations from yesterday, catch some of those if you didn't. But we do want to thank our sponsors, and we are grateful to you as experts who lend your time to events like this, but importantly to patient care. So thank you very much. Thanks everyone for being here. We really appreciate it. Thank you, David. Great moderation over these last 2 days. Such awesome time. Thank you. Thanks everybody.